to Podcasts on Demand, a continuing medical education activity. This activity includes the most recent and current clinical data presented by leading experts. If you are seeking continuing education credit, please review the disclosures and the requirements for successful completion of the activity prior to listening to the podcast. A link is found in the podcast description that can direct you to this information.
Hello, I'm Dr. Kris Kowdley, Director at Liver Institute Northwest and Professor at Elson Floyd College of Medicine, Washington State University. Welcome back for episode 2 of Clinical Clips from the 2024 EASL Congress titled Key Breakthroughs in the Treatment of Primary Biliary Cholangitis. The first abstract we'll review is efficacy and safety of seladelpar in patients with primary biliary cholangitis and compensated liver cirrhosis in the open-label, long-term ASSURE safety study. Interim results, and these data were presented by Dr. Stuart Gordon from Henry Ford Hospital in Detroit. So seladelpar is a selective PPAR delta agonist that has been shown to be effective in patients with primary biliary cholangitis in a phase 3 trial. Primary biliary cholangitis is a chronic progressive autoimmune cholestatic liver disease, and alkaline phosphatase and bilirubin have been identified as key markers for adverse prognostic events with elevated levels predicting future clinical events. And therefore, new therapeutic agents have focused on reducing alkaline phosphatase and total bilirubin in patients with PBC. The legacy patients with cirrhosis included 196 patients who were screened, 179 received seladelpar 10 milligrams, and there were 35 patients with cirrhosis who were identified. Key demographic features of the ASSURE cirrhosis patients: average age was 60, 91% were women, 71% white, 17% Asian, 8.6% American Indian or Alaska Native. Average BMI was 27.2, and 14% previously had received OCA and or fibrates, and 3% were URSO intolerant. Legacy patients with cirrhosis did achieve rapid, durable, and composite biochemical responses. As of month 1, 60% of patients achieved the composite endpoint, and this increased to a high of 67% at month 6, and at month 24, 65% of patients on seladelpar 10 milligrams achieved the composite endpoint and maintained the composite endpoint beginning as early as 1 month. Results were consistent with the overall population. Rapid and durable ALP normalization was observed in a subset of patients with a peak of 49% achieved at month 6, 47% at month 12, and due to a smaller number of patients with follow-up, 24% were described to have a normal alkaline phosphatase at month 24, 4 out of 17 patients. Total bilirubin remained stable in the cirrhosis population and in the setting of ALP reduction. There was also a reduction in GGT and ALT in the cirrhosis population, and overall serious adverse events were observed in a subset of patients, with 8 patients demonstrating liver-related adverse events, or 22.9%, and 8.6% of patients, or 3 patients, describing muscle-related adverse events. There were no treatment-related serious adverse events, and serious adverse events, each observed in individual patients, were noted without a particular pattern, and 2 serious adverse events were liver-related. The liver-related adverse events included evidence of liver decompensation, such as ascites, varices, 1 patient each with a liver lesion, hepatorenal syndrome, ocular icterus, and oral hypertensive colopathy and esophageal varices. So the authors concluded that in PBC patients with cirrhosis from the ongoing ASSURE long-term extension study, treatment with seladelpar led to clinically meaningful improvement in markers of cholestasis, and seladelpar appeared overall safe and well-tolerated in this patient population, and that seladelpar has the potential to be an option for PBC patients with compensated cirrhosis. Important caveats are that the number of patients with extended therapy was low, and although there were a collection of liver-related serious adverse events, we know that progression of liver disease and complications of liver disease is not uncommon in patients, as there are competing priorities between potential efficacy of therapies, and potential progression of the liver disease. So these data would suggest that seladelpar may have a role in treating patients with cirrhosis. Of course, additional data are required to determine whether treatment with seladelpar compared to placebo would actually reduce liver-related clinical events in an event-driven trial, and such a trial is currently underway. The next abstract is titled Elafibranor Efficacy in Primary Biliary Cholangitis According to Biochemical Response Criteria in the Phase 3 ELATIVE trial, was presented by Mark Sonderup from University of Cape Town in Cape Town, South Africa. So as we know, PBC is a rare autoimmune chronic cholestatic liver disease, and elafibranor, an investigational oral dual PPAR alpha delta agonist, had shown evidence of significant biochemical response in patients with PBC at week 52 in the Phase 3 ELATIVE trial, and showed a significantly higher rate of composite biochemical response compared to placebo. The Phase 3 ELATIVE trial randomized patients to either 80 milligrams of elafibranor or placebo for 52 weeks. A subset of patients had extended treatment and observation up to 104 weeks. Responder rates at week 52 favored elafibranor over placebo across PARIS-1 and PARIS-2 criteria. So PARIS-1 showed 69% had a biochemical response versus 47% in placebo, a treatment benefit of 22%. PARIS-2 showed 43% versus 6%, a treatment benefit of 37.5%. Barcelona showed a 55% treatment benefit compared to 0 in the placebo, so a treatment benefit of 54.7%. The MoMA-Linder criteria showed 52% versus 9%, a treatment benefit of 42%. And complete biochemical response, although uncommon, was only observed with elafibranor, and 9% of elafibranor patients versus 0% of placebo patients showed a complete biochemical response. When we look at odds ratios of elafibranor versus placebo biochemical response across the criteria at week 52, for primary endpoint, it was 37.56 odds ratio, followed by, in order, PARIS-1, 2.85, 16.65 for PARIS-2, Infinity with Barcelona, MoMA-Linder 15.42, and Infinity for complete response, given that 0% of patients achieved Barcelona and complete biochemical response. When we look at responder rates at week 52, a complete biochemical response was observed with elafibranor at 9%, as I've already mentioned. So the authors concluded that the rates of biochemical response with elafibranor versus placebo, according to multiple response definitions, further demonstrate the treatment efficacy in patients with PBC, and irrespective of the criteria used, treatment with elafibranor consistently led to biochemical response in a significantly greater proportion of patients compared with placebo at week 52. Although these results are not unexpected, it is very useful to evaluate how different treatment responses might be with these various prognostic models. And since many of them have been used for incorporation into clinical trials, this study provides a very interesting and granular analysis of how these models may apply to evaluate treatment differences. The next abstract is a poster that we will review, titled Stabilization of Enhanced Liver Fibrosis and Liver Stiffness Measures in the Open Label Extension of the Phase 3 POISE trial of obeticholic acid for the treatment of primary biliary cholangitis. And this study was presented by Dr. Robert Gish. So primary biliary cholangitis, as we've already discussed, is an autoimmune cholestatic liver disease that's relatively uncommon, characterized by fibroinflammation in the portal areas of the bile duct due to an autoimmune injury to bile ducts that then leads to complications of liver disease if untreated. Obeticholic acid was approved for treatment of PBC based on biomarker improvement in POISE, a 12-month randomized double-blind placebo-controlled trial. Transient elastography is a non-invasive alternative to biopsy to evaluate liver stiffness and indirectly assess fibrosis which can be predictive of adverse outcomes in patients with PBC. Enhanced liver fibrosis test, or ELF, is a blood test that consists of an algorithm of 3 fibrosis markers, namely P3NP, hyaluronic acid, and TIMP1, and is a well-validated measure of fibrosis. This interesting study examined the results of a post-hoc analysis of the impact of OCA on transient elastography and ELF in patients from POISE. Patients were initially allowed to titrate to greater than 10 milligrams, but eventually, in line with the approved label, doses were reduced to no more than 10 milligrams. OCA stabilized ELF over 24 months in patients with evidence of moderate or severe fibrosis or cirrhosis at baseline. In patients with moderate fibrosis, the mean ELF score was 9 at baseline, 9.19 at month 12, and 9.31 at month 24. In patients with severe fibrosis, mean ELF scores were 10.35 at baseline, 10.36 at month 12, and 10.56 at month 24. In patients with cirrhosis, mean ELF scores were 11.92 at baseline, 11.54 at month 12, and 11.35 at month 24. OCA further stabilized elastography measures over 24 months in patients with transient elastography values of less than 10 kilopascals or greater than or equal to 10 kilopascals at baseline. In patients who had normal liver stiffness defined as less than 10 kPa, the mean elastography values were 6 at baseline, 6.37 at month 12, and 5.86 at month 24. In patients with higher levels of liver stiffness, greater than 10, the mean values were 19.3 at baseline, 18.39 at 12 months, and 17.37 at 24 months. ELF and TE values after month 24 were similar in those patients, were similar to those observed from baseline to month 24, although the number of patients with ELF and TE measures decreased over time through month 12. Based on these results, the authors concluded that there was no evidence of worsening in non-invasive measures of fibrosis using ELF and TE throughout the OCA treatment period, and that these results suggest that OCA stabilized fibrosis over time, regardless of severity at baseline, although the interpretability of the data is limited because of reducing number of patients available for evaluation over time. They further concluded that cumulative changes in ELF and TE over time were reduced to a greater extent in patients with higher fibrosis stage, and earlier treatment may be beneficial in preventing worsening of fibrosis. So this study is very important in that it shows using measures that we are likely to use in clinical practice that we can measure repeatedly that are non-invasive, such as ELF and elastography, can be useful in evaluating stability, improvement, or worsening of fibrosis over time. What's further interesting is that the patients with the highest level of expected fibrosis based on these measures appear to have the greatest improvement, and patients who had lower levels demonstrated stability or fairly low rates of what we would consider possible progression. So in total, I think these data are very useful because of the longitudinal amount of information collected, that we have treatment out to 5 years with open label OCA therapy. And we can infer from these data that at least with regard to fibrosis assessment using non-invasive tools, OCA showed stability and no worsening of fibrosis, and potentially a greater likelihood of response in patients with the greatest unmet need. Of course, additional data are needed from real-world data to confirm these findings, but they are reassuring for those patients who have already been on OCA for several years and if treated appropriately according to the label. The final abstract we'll review on PBC from the EASL Congress 2024 is association of elevated liver biochemistries and clinical outcomes within strata of alkaline phosphatase levels in patients with PBC. And these data were presented by Dr. David Victor from Houston Methodist in Houston, United States. We know that in patients with PBC, elevated liver biochemical tests and the duration of elevation are correlated with increased risk of negative clinical outcomes, including hepatic decompensation, liver transplant, and death. The goal of this abstract was to review the relationship or assess the relationship between the degree of elevation of liver tests, namely AST, ALT, and two fibrosis assessment tools, FIB4 and AST platelet ratio index, or APRI, within different strata of alkaline phosphatase. The authors used the Komodo healthcare map merged with national lab data between July 2014 and February 2022. Inclusion criteria were those diagnosed with a diagnosis code of PBC. The date of the first claim was set as the index date. Patients were required to have more than 6 months of continuous enrollment, more than 18 years old at index, had more than one biochemical measurement of alkaline phosphatase, T-bili, ALT, and AST during the baseline period, 6 months before and including the index date, and at least a day until the end of enrollment, death, liver transplant, or a clinical event. Patients with a history or presence of other concomitant liver diseases were excluded, as were those who already had evidence of hepatic decompensation, abnormally high liver biochemistry tests that may have been due to something else, low platelet counts, and patients were stratified into three groups based on baseline ALP less than or equal to ULN, upper limit of normal, greater than upper limit of normal but less than 1.67, and greater than 1.67. Within each stratum, a multivariable Cox proportional model was used to assess association between a time-varying covariate and the composite endpoint, namely hospitalization for liver decompensation, liver transplant, or death. And within each stratum, a separate model was run for each biomarker or fibrosis score. Fixed effects of age, sex, non-alcoholic steatohepatitis, cirrhosis, portal hypertension, and autoimmune hepatitis were accounted for. And the time-varying covariate included ALT, AST, FIB4, and APRI expressed categorically as multiples of upper limit of normal. Authors evaluated the data. What they showed is that the risk for events by ALP strata for each biomarker or fibrosis score was further influenced by ALT and AST elevation and was also influenced by the degree of elevation of alkaline phosphatase, with progressively higher risks in patients with higher alkaline phosphatase, but also influenced by AST and ALT. So among patients with a baseline ALP less than 1.67, patients with ALT that were more than twice upper limit of normal had a higher risk of negative outcomes. Compared to patients with an AST less than upper limit of normal, those with an AST greater than 1.5 times upper limit of normal also had a higher risk of negative outcomes, regardless of ALP strata. And regardless of ALP strata, patients with APRI scores greater than 0.5 or FIB4 greater than 3.25 had consistently increased risk of negative hepatic outcomes compared to those with APRI scores less than 0.5 or FIB4 less than 1.3. The authors concluded that irrespective of ALP strata, even when ALP is less than upper limit of normal, elevated biomarkers, ALT, AST, and fibrosis score were associated with increased risk of hospitalization for hepatic decompensation, liver transplant, or death, highlighting the importance of comprehensive and timely monitoring and treatment of patients with PBC. This very important study shows that we can't just look at ALP as a static measure and be satisfied when the alkaline phosphatase alone is shifting in a direction that we want, or be reassured if the alkaline phosphatase is normal, but if aminotransferases are elevated or if fibrosis scores are elevated. And it really speaks to the importance of a comprehensive assessment of patients that incorporates liver enzymes, liver synthetic function, alkaline phosphatase elevation at any level, and presence of advanced fibrosis, such using even simple tools such as such as FIB4 and APRI score. And as we move towards a greater emphasis on complete biochemical normalization, or at least ALK-Phos normalization in patients with PBC, this study reminds us that we need to also be looking at other liver biomarkers, fibrosis stage, in assessing the adequacy of treatment for patients with PBC. Thank you for joining me for this clinical clip series from the 2024 EASL Congress. Please refer to the landing page for slides and to claim your continuing education credit. And thank you for your attention.
We hope you found this podcast useful and educational. To receive continuing education credit and to download your printable certificate, please go to the activity page at practice.cme.com to complete the post-test and evaluation to receive continuing education credit.